Hello, my name is Dr. Victor Urrutia. I'm an associate professor of neurology at Johns Hopkins University, and I am the director of the Comprehensive Stroke Center at the Johns Hopkins Hospital. I'm going to talk about acute treatment of stroke and give an update of the current state of acute stroke treatment. So my objectives today are to discuss the treatments of acute ischemic stroke, discuss new imaging techniques in evaluating acute ischemic stroke patients, and review the benefits and principles of organizing stroke care. So the treatment of stroke has gone a long way in the last 23 years. Since the publication of the NINST IV-TPA trial for acute ischemic stroke in 1995, through the extension of the time window from 3 hours to 4.5 hours, and then the demonstration of the benefit of thrombectomy in 2015 with the publication of 5 clinical trials that showed benefit without a doubt. In 2017 and 18, the window was extended to 24 hours with advanced imaging by the DAWN and Diffuse 3 study. Intravenous thrombolysis is still the only FDA-approved drug treatment for a stroke, and it's still recommended that every patient that qualifies for this treatment should receive it. And the rationale for this is that it's a treatment that is quick and easy to administer. It can be administered in more hospitals than, for example, thrombectomy can be administered. And as I'm going to show you in a slide next, is that most patients are actually stroke patients that don't have large aortic occlusion. Now, very little has changed in intravenous thrombolysis since 1996 when it was approved by the FDA, except for the time window, which was extended from 0 to 3 to 4.5 hours. And the other thing that has changed is that there's been a recognition that patients that have mild symptoms also have a 30% chance of having disability and therefore deserve treatment. So a task force was created to try to define what are the patients that have a low severity of stroke symptoms that would be most likely to continue to be disabled and therefore warrant treatment with acute intervention like IV-TPA. And what the task force found was that you could summarize it in 3 items, which include a complete hemianopsia or severe aphasia. These patients often have an NIH stroke scale of 2 or 3, and if you went by stroke severity, they might be considered for not being treated. However, these have been identified as significant symptoms causing disability, and therefore those patients merit treatment. Having visual or sensory extinction is another condition that would portend a high risk of disability, so it would require treatment. Having any weakness limiting sustained effort against gravity is also considered a significant deficit. And in this one, you also have to consider what the patient's baseline is. If you have a patient that works with their hands, any weakness in their hand that is going to affect dexterity is going to be a source of disability in the future and should be considered for treatment. And any deficits leading to a total NIH stroke scale of 5 or above should be a deficit that needs to be treated. At the end, it also is recommended that the physician considers the overall goals of care of the patient. And as I mentioned before, if a patient has mild hand weakness, but hand function and dexterity is intricate for their livelihood, that is something that should be considered. The other part of this is not only the patients that present with symptoms that are mild, but also patients that present with more severe symptoms and then improve to a level where they're mild. Those patients should be treated. The benefits of treating with IVTPA are higher than the harm. And in this slide, you can see that from 0 to 3 hours, the numbers needed to treat to get a benefit is 8. And from 3 to 4.5 hours, the numbers needed to treat is 14. What that means is that you need to treat 14 people for one to benefit. If you compare that with coronary intervention, so PCI for acute MI, which has the numbers needed to treat of 34 according to some studies, the treatment with TPA is actually highly effective. Now, if you look at the bar graph, you can see that time is definitely brain, and the earlier that you treat the patients, the more benefit you're going to derive. And here in the 0 to 90-minute window, you have a 27.8% chance of excellent outcomes, and you have a 1.5 chance of poor outcome. So the poor outcome risk increases over time, although not at the level of the benefit. It's still beneficial up to you get to 4.5 hours, and after that, then you lose the benefit. This is what I was referring to before. Most patients, this is a bar graph of the NIH stroke scale on the x-axis, and the percent of patients presenting as an acute stroke. And you can see that most patients are presenting with an NIH stroke scale less than 10, and definitely less than 6. So what that means is that most patients are going to be patients that don't have a large artery occlusion, and therefore IVTPA is going to be the only treatment that you're going to be able to offer to increase their ability to recover. Mechanical thrombectomy has definitely been a revolution after 2015, where it was shown that the numbers needed to treat was 4. So if you remember the TPA numbers, the numbers needed to treat for 0 to 3 hours was 8, and from 3 to 4.5 hours was 14. For thrombectomy, which are the large artery occlusion patients, which are the patients with the highest mortality and risk for disability, the numbers needed to treat to get somebody back to independence is 4. So 1 out of 4 patients are going to be back to independent in 90 days. And with the new studies, we are able to extend the time window to 24 hours if we do advanced imaging. So the Hermes is a pooled data analysis of the 5 endovascular trials, and you can see that there were 634 intervention cases, 653 controls. The median time to treatment was 3 hours and 16 minutes. So you can get the sense that the patients are being treated very fast in these trials. 71% recanalization, numbers needed to treat to reduce 1 point in the ranking score, which is a score of disability, was 2.6. And the overall numbers needed to treat was 4. In terms of detecting patients that are beyond the 4.5-hour window, there's 2 approaches that have been successful. One is to try to determine if the stroke is truly within the 4.5-hour window, and this is the approach that has been taken in the MR Witness, which is a clinical trial from the US that was published some time ago, and the Wake Up Stroke, which is a clinical trial from Germany, in which they used the paradigm of DWI Flare Mismatch. What the studies have shown is that the number of patients that are going to have an obvious lesion in flare, which is the black bars here, increases over time. And the inflection point is really 4.5 hours. After 4.5 hours, most of the patients are going to have a flare lesion, whereas before, most of the patients are not going to have a flare lesion. So with taking this in mind, the idea is that if you have a positive diffusion weighted image lesion, like in this picture or in this picture, and you compare it to the flare, if flare is negative, that that patient might actually be within 4.5 hours. And what in this, the bottom panel, you can see that the DWI and the flare are matched. So with this paradigm, MR witness and wake up demonstrated that you could treat patients that you had no knowledge of the time of onset, and they could be treated safely with intravenous thrombolytics. There's been other studies from the US, also the Wake Up study and the Ceylon study, where patients were treated with wake up stroke based on their non-contrast head CT or based on the MRI diffusion flare mismatch. Now, the concept of the perfusion imaging comes from this slide, which was presented by Greg Albers in the International Stroke Conference in 2013, where the volume of the infarct and the y-axis compared to the time from stroke onset shows that in the first few hours of the stroke, most of the patients are going to have a low volume, but there's going to be a few outliers that have a large volume of stroke that is irreversible. However, you would think that all the patients in the later times are going to have a high stroke volume, but in essence, what the studies have shown is that there's a significant number of people that are going to have a volume of stroke that is less than 50 cc's, even at 24 hours after the onset. And using this paradigm of trying to identify how much of the core, which is irreversible, is present, has been successfully used by the DAWN study, the Diffuse 3 study, the Extend study, and the Extend IV studies. And that has led to really a revolution in treatment of acute stroke with perfusion imaging up to 24 hours for large artery occlusion. These are the criteria for the DAWN study. They divided patients in 3 groups by age and NIH stroke scale. In the DAWN study, it's really a study of severity of stroke versus core. So it's a severity core mismatch in which the core was determined by the CT perfusion. So in group A, patients that are 80 years of age and older with an NIH stroke scale that is 10 or more, and a core that was exceedingly small, less than 21 cc's, could be treated with thrombectomy. In group B, patients that were less than 80 years of age with NIH stroke scale equal or more than 10, with a core less than 31 cc's, were treated with thrombectomy. In group C, patients that were younger than 80 years of age, NIH stroke scale more than 20, and core between 31 and 51 cc's were treated with thrombectomy. And the findings of this trial showed that the numbers needed to treat for better disability score was 2, and for independence was 2.8. Now, the reality is that this trial, even though it shows a criteria for a core less than 31 for group B and a core between 31 and 51 for group C, the median core size was less than 25. So this trial identified patients with very small cores and were treated effectively. Same thing happened with the Diffuse 3, which used a different paradigm in which they, instead of using the severity core mismatch, they did a perfusion core mismatch. So the criteria was ischemic stroke core of less than 70 cc's, a ratio of perfusion deficit versus score of 1.8 or more, and an absolute volume of potentially reversible ischemia of 15 cc's, 15 milliliters or more. And here you can see an example where the core is measured to be 23 cc's, and the perfusion deficit is much larger, measured out to be 128 cc's, and the mismatch volume is 105, which is greater than the 15 that is stated, and the mismatch ratio is greater than 5.6. It's like 5.6, which is greater than 1.8. So this patient qualifies for treatment. Now, as I mentioned before, the DAWN study had a median core size of 7.6 with an interquartile range of 2 to 18. Diffuse 3 had a median core of 9.4 with an interquartile range of 2.3 to 25. And so you can see that the most of the patients did not have a high degree core, even in the less than 70 cc range, but it was very smaller cores. However, the implementation of these two trials in clinical practice have been effective, and we're currently using those criteria for select patients for thrombectomy. What the future holds is that this same approach of perfusion imaging is showing good results in intravenous thrombolysis, and this trial reported efficacy at 9 hours from stroke onset. Now, this trial was not significant enough to provide change in practice, but it's definitely a step in the right direction in terms of extending the time window for IV thrombolytics. Now, I'm going to change track a little bit to talk about stroke units. There's a clear benefit for stroke patients to the creation of stroke units. They've been shown by several studies and meta-analysis, including a Cochrane database investigation, that the stroke units reduce mortality by about 20% and also disability. The effect size is comparable to that of TPA. What that means is that when you look at the numbers needed to treat to help patients with stroke get reduced disability, just by the basis of being in a stroke unit versus not a stroke unit, the number is about 18 numbers needed to treat, which is very close to the 14 that you see in the 3 to 4.5 hour window for TPA. What a stroke unit represents is really the determination of protocols that standardize the stroke care and stroke order sets, adherence to best practices, telemetry for 24 hours and then as needed, and then vital sign and neurologic assessments that are given by trained nurses. And one of the things that are more surprising but very effective is that bedside swallow evaluation, glucose checks, DVT prophylaxis, temperature management have demonstrated benefit in terms of stroke survival and recovery. And here is what I was mentioning, the Cochrane database systematic review showing the numbers needed to treat of 18 for stroke units, and also this study from Canada in which patients were randomized to centers that were offering swallowing, fever, and blood glucose protocols versus centers that were not. And there was a benefit in the functional outcome in the patients that were randomized to the centers that were doing swallowing screen, fever control, and blood glucose control, with the numbers needed to treat of 6.4, which is better than TPA. And that's a significant demonstration that organizing a stroke center with protocols and a stroke unit has a definitive effect in the outcome of stroke patients. It's important for the stroke program to have scales in triage to detect stroke, and one of the most used and most effective one is the BFAST scale, which includes 2 parameters for posterior circulation, which are balance and eyes. So the B stands for balance, the E stands for eyes, which is double vision or loss of vision, F for face weakness, A for arm weakness, S for speech, either dysarthria or aphasia, and T for time. There are other scales. There's the RACE, which is a modified NIH stroke scale. There's the LAMS, that is a face, arm drift, and grip strength that is very predictive for large artery occlusion. In the stroke center, you, in addition to what I've mentioned before, it's important to have a preset workflow for rapid assessment and evaluation of patients for both thrombolytic therapy and mechanical thrombectomy, and that includes a scale, a triage to detect the stroke, and monitoring airway breathing circulation, and then breaking down the 2 windows, 0 to 4.5 hours and 4.5 to 24 hours, which determines patients that could be treated. Within the 4.5 hour patients, All patients can be treated with either thrombolytic therapy or thrombectomy, and those patients are going to need to be evaluated by CT or CTA. In the 4.5 to 24-hour window, patients are going to need to be treated, are going to be qualifying for thrombectomy if they have large artery occlusion, and will require perfusion either by CT, CTA, CT perfusion, or MRI, MR perfusion. Essentially, these are the 2 time windows that I explained. IV thrombolytics in the 4.5-hour window, and patients that have large artery occlusion can be selected for thrombectomy in the 4.5 to 24-hour window by doing perfusion imaging. An acute evaluation, and this is useful for the emergency department doctors, especially to present to the stroke neurologist or the neurologist, is that, you know, the critical aspects is to have assess a time from last known well, and then assess a brief HPI, a brief history of present illness, quick exam, neurologic exam and physical exam, to do an NIH stroke scale. And this is important. All emergency medicine doctors should be proficient in the NIH stroke scale, as well as the neurologists, of course. But it's good for the emergency medicine physician that if they have the time of last known well, the HPI and exam and an NIH stroke scale, and they can go through an inclusion-exclusion form, then you can talk to a neurologist and expedite the decision to treat or not to treat a patient with IVTPA or thrombectomy. And documentation of this process is important. So in conclusion, in this day of multiple windows and treatments for acute ischemic stroke, logistics and organization of systems of care are vital. And the creation of stroke units to that end is a critical step. Increasing capacity and getting the right patient to the right place to the first time is key. The future of stroke is to make these treatments accessible to all patients, and organizing centers in the system is paramount. I hope you enjoyed this talk and look forward to having questions. Thank you.